This is Dr. Farhad Boltchi, and welcome to the Academy Online Implant Continuum. Starting with this webinar, we will start a series of surgical video presentations that will delve more into the detail of exactly how specific implant surgical indications are performed, and hopefully these videos will provide a good learning experience. In this webinar, we'll discuss the replacement of a congenitally missing canine. And also in subsequent videos, we'll not only show the surgical video demonstration, but also the planning that goes into a lot of these cases, because that is equally, if not more important. This is a case that we performed several years ago as part of our mentor meeting, as far as our seminars, live surgical demonstration seminars. This was a patient who presented with a congenitally missing canine, tooth number 6, specifically the upper right first canine, and she still had the deciduous primary canine in place. Now, this patient ideally needed some orthodontic treatment as well, but she did not want to undergo orthodontic treatment. Her main concern, her chief complaint, was just the fact that she had this canine, this baby tooth, this deciduous tooth that was kind of sticking out in her smile and kind of ruining her smile and leading to asymmetry, and the view of the spectator was drawn exactly to this side. So this was an unsightly site for her that she had lived with for many, many years. Obviously, she was in her mid-20s when we started treating her. So her chief complaint, and the only thing that she wanted to address at this point, was to take care of this canine. So this is the retained primary canine. As you can see, it is obviously somewhat unsightly, but the gingival tissues look good. And so we start our planning of placing an implant here, ideally in an immediate fashion. Now, our goal, if possible, was to plan this case so we can place the implant immediately at the time of extraction of this deciduous tooth, and then, if at all possible, also temporize this implant immediately with a CEREC tempori that is done immediately at the time of the procedure. So here's the planning that we performed, and the planning is somewhat interesting in this case because as is the case with a majority of these cases where there is a congenitally missing tooth, there is a deficiency of the bone. Most of the time this is not a vertical deficiency, but rather a buccolingual deficiency. It can be a vertical deficiency if, for example, the tooth is ankylosed. Here we can see, if we bring in the optical impression and look at it, we can see how we have planned this case. We have planned to place an implant here so that it exits through the incisal edge. Now, in this position of planning this implant the way that it is, you can see here the implant is emerging through the incisal edge of the restoration. We will have a deficiency on the buccal that we would have to bone graft. Now, if we look at it closer, we could place this implant in the trajectory of the ridge. However, then the implant would exit about 25 degrees to the facial aspect of this restoration. Now, that can obviously be fixed with a custom abutment. That is not the issue to restoratively fix that. However, if we plan it that way in aesthetic areas, then the custom abutment typically has to go through the facial to come back out, and that pressure of going through the facial a lot of times puts too much pressure on the gingival tissues and puts the gingival margins more apically. So in aesthetic areas, when I plan these cases, I like to plan them more ideally so that they are not really emerging past the incisal edge. And that would be my advice to you when planning these cases as well. Plan these cases so that the emergence, or where the implant access is coming through, is not past the incisal edge. If you do go past the incisal edge, then you can end up with a little bit of too much pressure on the buccal, and that can lead to recession in these aesthetic areas. And in these type of cases, I would rather do the bone grafting and take that into account, especially in a case like this, rather than having to risk recession down the road. Now, this type of bone grafting that has to be done in this case would be very predictable because this implant now is located within the bony housing. As you can see, there is a facial fenestration that will ensue upon placement of the implant in this position, but we have got very nice thick crestal bone, and that apical fenestration is easily graftable and easily can be easily managed surgically. Also, you can see here, if you change this to a 12 millimeter implant, then we're not going to be able to engage a whole lot of bone apically. So this is a 14 millimeter implant that was planned. Now, this case was done several years ago before the Straumann bone level tapered implants were available. At this stage, we do have the Straumann bone level tapered implants or any other tapered implant. So I would have planned this case for a tapered implant nowadays to give myself a little bit room. I've also been asked on this type of case, why not place a narrower implant, which can be done. However, even if you place a narrower implant in the ideal restorative position as shown here, you still are going to be too close. You can see here, this is the narrower implant, and we're still going to end up with a slight fenestration defect. Even if you move the implant more palatally, we still have a very thin buccal plate in this case. And when we have a very thin buccal plate in this type of case, then I typically, since we have to graft this anyway, I would prefer to place a 4.1 millimeter implant, especially in a case like this on a canine, which in this patient's occlusion is going to be a major load-bearing tooth. So I would rather do a 4.1 millimeter implant since we have to graft this case anyway. Then that way we can basically have a stronger implant. Here is the example as shown here. If we tilt the implant so it's in the trajectory of the ridge to where we would avoid bone grafting, and that can be done, but you can see the implant is now emerging totally through the facial at about 25 or 30 degrees. Here you can see it better in the 3D view, and that requires a custom abutment, which again is not a problem restoratively, but the custom abutment, in order for it to correct this angle, first it has to go out facially and then come back to the palatal, and that aspect of it going facially can put too much pressure on the tissues and therefore cause a recession. So again, I prefer to place the implants such as in this manner, to where they're emerging really more not anything past the incisal edge in aesthetic areas. And in this case, we just have to take into account that we will do this bone grafting at the time when we place the implant. So here's the more ideal position of the implant, requiring that grafting of that facial fenestration. And again, this is a 4.1 millimeter by 14 millimeter implant. A 3.3 implant would still require bone grafting, and a shorter implant would not engage enough of that apical bone, especially since we are going to immediately provisionalize this case. We want to gain as much stability as we can. So this is the plan. So you can see here what nuances go into the plan to plan a case like this, ideally and optimally for an optimal outcome. So with this plan now, we'd send this case to have an OptiGuide fabricated. Obviously nowadays you could do this case either with a CEREC guide 2, either milled or printed, or you could also do it with a CCAT digital guide. A lot of times in aesthetic cases such as this, I prefer to use a CCAT digital guide, but it can also be easily done with a CEREC guide 2. So here's on the day of the surgery, this is the surgical video. So this is the preoperative condition, obviously, of this patient with the retained primary canine, as we showed previously. And then on the day of the surgery, we go ahead and basically apply topical anesthesia. We typically use a compounded anesthesia, either TAC 20 or best topical ever. And then the local anesthesia in the standard fashion. And this is the preoperative scan taken before the procedure, so we can get all of our preoperative scans. And here's the basically the line started, the IV line to draw blood for PRF. Now the extraction of this tooth is obviously not too difficult. This is a retained baby tooth with a short root, but I typically like to use these apical retention forceps that can be purchased from Carl Schumacher. There are several other companies too. They engage the roots deeper and still try to extract this tooth with very minimal trauma. Here's the OptiGuide in this case that was fabricated by CCAT. It's placed, it fits very well. And this case was obviously planned for Straumann guided surgery. So here's the Straumann guided surgery kit with the different handles and keys and the different drills. Pretty straightforward kit. For those of you who are not Straumann users, this is very straightforward. For those of you who are, You know how this works. Other surgical kits are similar. Some of them are keyless, some of them are with keys. However, keys are not a problem in the anterior area. You can see here that we have placed a bite block on the right side to on the left side to stabilize the guide, and then the keys get stabilized, and then the drilling sequence commences here with the sequential drilling with the Straumann guided surgery system. So we first, without flap reflection, go ahead and prepare our osteotomy here with this through this optic guide. This is pretty standard. Just make sure when you do this, you do a very nice slow pumping motion up and down, and then also in between the osteotomies, take the guide off, and then yourself and your assistant make sure you rinse the side out thoroughly with chilled saline solution. That way you avoid overheating the bone, which can be detrimental. So now that we have prepared the osteotomy side, we go ahead and access this site, the apical fenestration for grafting. I did not want to make an incision crestally because we were going to temporize this case immediately. So we do an apicoectomy type of incision, kind of a semilunar incision through keratinized tissue. Make sure that this incision is in keratinized tissue. If you don't have any keratinized tissue, then that might be a contraindication for this type of incision. And then here, this is sped up a little bit, but a full thickness reflection of that apical flap, again, leaving the crestal area intact. This then accesses the apical fenestration. But before we do any type of grafting, obviously we place the implant now through the guide, fully guided. The flap reflection apically is done before the implant placement so that we don't have to scrape the flap off of the implant surface with our periosteal, so that that area is, the flap is reflected apically there, and then we place the implant so that then nothing really but blood touches the implant surface. So here's the fully guided implant placement. Typically, I like to place these with a hand ratchet. A lot of other people like to use the handpiece. That's just personal preference. These are the old style mounts that still had to be taken off. The guided mounts nowadays, this is not necessary anymore because now we can use the universal Loxim mount with guided drivers so that this does not have to be removed. But with this old type of mounts, we had to remove them, which is not a big deal as well. So this is the removal of that mount, and you can see now the implant has been placed the correct depth, and we place a healing cap over the implant, and then we do the bone grafting. The bone grafting is done in layered technique. This is a corticocancellous allograft first, a mineralized demineralized blend. I typically like to use a product from Maxius, which is a mineralized demineralized blend. Other companies have this product too, but I like the Maxius bone, and this is then applied as a first layer. Second layer is then a xenograft, typically BioOs, and then a resorbable membrane on top of that, such as a pericardium membrane, and then PRF membrane over that. So those are the layers apically, and then here the suturing. So the first 3 sutures are tacked here in the middle and on the corners with a 6 polypropylene suture, and these are done, and then the rest is done with a resorbable plain gut or chromic gut suture. Once that is done, now we can go ahead and do our additional CEREC scans. This, for example, we can scan our gingival mask. At this point, once we have done this and completed the surgery, here we can do the gingival mask scan with the CEREC, and this is all done for the fabrication of the immediate provisional. And here, once that's done, then we can take the healing cap off and then place a scan post. Now, obviously, in order to place this scan post, a lot of times you have to do some bone profiling. That's not shown in this video, but that is crucial to get the bone out of the way so that you can seat this scan post and the subsequent tie base restoration properly. So here's the scan post that's been seated, and then the scan body that then lines up with the notch in the scan post. Here you can see how nicely that is then placed over that area, and then this becomes our scan post, scan body that we're going to scan for the CEREC. Obviously, in the CEREC machine, We cut out this area, so then at this point we just have to scan only the scan body very quickly, and this is a very quick scan. In practice, a lot of times I do all the pre-op scans beforehand so that during surgery we only scan the scan post. So here is scanning the implant position with the CEREC OmniCam. Again, very straightforward. Here, these are all standard procedures nowadays for CEREC users. And this is just a quick scan of the scan body. You really don't need to capture that much more, just the scan body and a little bit of the adjacent teeth, and then the software then merges those scans together accurately. So here's the scan that is being done, and obviously the apical area is sutured, and now we just scan the scan post and scan body. Once that is done, then we go ahead and design and mill a TeleoCAD restoration, in this case, that is then bonded to a tie base, Straumann Vario base for CEREC in this case. This process takes about an hour with the designing, milling, polishing, bonding to the tie base. The patient can wait in the meanwhile, and once that is done now, then we can go ahead and seat the restoration kind of immediately. Obviously, in the design phase in the CEREC, make sure that this restoration is taken completely out of occlusion, eccentric, and all excursive movements. So it's a good idea to turn on the virtual articulator in the CEREC and to take those contacts all away. Once we place this, this is not torqued into place, but rather hand tightened. So if you wanted to measure the hand tightening torque, it would probably be about 15 newtons, but it's only hand tightened. Never use a torque wrench on this here. And then obviously make sure to check the occlusion so that it's completely out of occlusion. That is really, really important. There should be absolutely no occlusion in any centric or excursive movements. At times when that's the case, the provisional, you can see here, there's absolutely no contact. At times when that's the case, the provisional becomes a little bit shorter and sometimes may not look as pretty as a typical provisional, but that is just the compromise that you have to make when you immediately temporize these type of cases. Really, really important, again, to check it in all excursive movements. Just make sure there's absolutely no contact on that provisional. So once that is done, then we go ahead and close the access hole with just a Teflon tape that is placed into the access hole. This is again a very standard procedure. And then the screw access hole on the top, you can either seal off with composite, such as we did in this case, or typically I like to use a product called Teleo if the screw access hole is a little bit more palatable. In this case, it was right through the incisal edge, so the composite had to be done. Otherwise, the Teleo restoration that is real nice, because that can then just be placed very quickly. It's light cured, but then later on it doesn't have to be drilled out. It can just be plucked out. So here's the light curing of the composite restoration in the screw access hole. And so this then completes the surgical phase of this treatment. So very straightforward, one-step surgery, placing the implant immediately, bone grafting, again with that apical incision. This is a 1-week post-op. You can see here that incision apically heals up very good. Typically we remove the sutures at 2 weeks. I really don't see the patients before 2 weeks. And then this is a 4-month post-op. Typically we don't have to wait that long. I usually only wait 2 months. That's enough with these Straumann implants. And then after about 2 months, in this case it was 4 months, we take that temporary off. We can take another scan if we want, and then fabricate an Emax restoration. This was a cemented restoration. This time that was fabricated by Drs. Puri, Fleming, and Scramstead. So an Emax restoration bonded to an Emax hybrid abutment. You can see here the close-up on the day of the seat. Very nice shading, and this is a cemented restoration on, again, an Emax hybrid abutment, all done in-house with the CEREC technology. Obviously, we had to do a cemented restoration in this case just because the screw access hole, as was visible previously, was emerging through the incisal edge. So this is the final restoration, and again, just to recap, this is the 4-month post-op here, and once we take that provisional off at 4 months, we can see the nicely maintained or developed peri-implant tissues. And then at this stage, then we can go to the final restoration. Again, this was an Emax crown cemented onto an Emax hybrid abutment, which was bonded to a tie base, all done in-house with the CEREC. Here's a close-up of the final. And then we were able to recall this patient back at 18 months, and at 18 months, once we recalled the patient, we could observe that the restoration was still blending in extremely nicely with her smile. She was extremely happy now that she didn't have that congenitally retained deciduous tooth kind of ruining her smile. Here's the close-up of this Emax restoration that was done. Again, it blends in real beautifully with her natural teeth, and even if you compare it to the contralateral canine, it really blends in very nicely here in her smile and in her dentition. Again, ideally she would have needed orthodontic treatment, but she declined, but still we were able to give it a really, really nice smile, maintaining all the papillary form and the gingival margin as well. Now you can see here that the gingival margin is exactly at the correct location, which is 1 millimeter apical to the lateral here in this case, kind of corresponding to the contralateral canine. And this is a function of placing the implant to the correct depth, which is 3 to 4 millimeters apical to the facial gingival margin, but also a function of the correct contour of the provisional restoration and especially the final restoration. If you have the correct contour on that restoration, the tissue will adapt to it in the correct position if your implant is placed to the correct depth. So all of these things, treatment planning wise and execution wise, go hand in hand to end up with a perfect gingival margin. Because if you remember here, you can see the occlusal view of her occlusion. Obviously the teeth had to be rotated slightly just because of her occlusion. We also took a post-op CT scan here after 18 months. This is the 3D view, and then after 18 months we can see how nicely that bone graft that we did apically has blended in, and the patient now has a nice at least 2 millimeters thick facial plate in those areas surrounding the implant completely. And this implant restoration should serve her really, really well for a very, very long time because this is a very stable result now with this nice bone surrounding the implant, a stable implant, a nice restoration. So altogether, a very nice biologic, functional, and aesthetic outcome. So I hope this has been helpful as our first surgical video presentation. We'll continue this series with different indications and with different surgical videos so you can get an idea of how these cases are actually performed. And then obviously if there are any questions, please feel free to ask or post them on the boards.